Thursday, March 14th has always had a warm spot in the eye of stat geeks because it's Pi Day, 314 being the first three digits in pi. But from here on forward, it will have a really special place in the heart of everybody involved in MASH and MASLD. It was the day the U.S. approved its first drug for MASH. Today, Surfing the MASH Tsunami holds a special episode with 5 of the people most excited by this approval. Patient advocates for leading liver and MASH organizations, many of whom are patients themselves. We'll discuss their feelings about it, what they see on the road ahead, and what lessons we can learn today on Surfing the MASH Tsunami.
Today on Surfing the MASH Tsunami.
Just the hope that this drug brings is what really struck me. This approval kind of shows the way to what can happen in the future.
I get slightly fed up with the excuse that people give of overwhelming the system. We would have to change the system very drastically, very quickly to overwhelm it. What we need to do is start pushing the needle to build the capacity in the system.
I think Wayne, as an F4 patient, doesn't have access to this drug right now. And so does that mean that in the future that an F4 patient wouldn't have access to this drug? It means now that we have approval, now these are the sort of questions we can begin to ask.
We really made our opinions about that visible to the FDA, and as a group, as the patient advocacy community was, I think, instrumental in the fact that this label does not have biopsy.
We're going to be actually doing, Louise, market research across Canada, almost 27,000 primary care physicians to find out what challenges they're having with regard to access to non-invasive testing. Yeah, it's going to be really, really big.
Ken Kuzi's been talking forever about the idea that the best thing we could do is get everybody checking a diabetic patient to add a liver check once a year. The same way you check kidneys, check eyes, right? That would bring primary care into the game, Louise, in the way that you're describing.
I take medication for anxiety. I take medication for depression, and nowhere on that label does it say I should use in conjunction with therapy. And I think that this really does open the doors for the FDA to think about this in a more broader picture of what we can promote to really treat some of these other comorbid conditions.
The FDA's approval of Rezdiffra on March 14th was historic for the global MASLD and MASH community. We now have an approved drug for MASH. Today, join liver health advocate Louise Campbell, pricing and forecasting guru Roger Green, and this week's guests, patients and patient advocates Wayne Eskridge and Jen Jones of the Fatty Liver Foundation, Tony Vigliotti of NASH Knowledge, Mike Patel of the Fatty Liver Alliance and Liver Action Network, and Global Liver Institute Vice President of Liver Health Programs, Jeff McIntyre, as they share their excitement about Thursday's announcement and consider what it means for patients now and in the future. This week on Surfing the MASH Tsunami.
Remember to stay tuned after this episode for this week's question of the week.
So, as I mentioned in the original introduction, Pi Day has always been a thing for stat geeks, but now it's a day for liver people as well. And last Thursday, Pi Day, at 4:17 in the afternoon, plus minus a minute, FDA approved what was formerly known as resmetirom, and that's still the molecule, but is branded now as Rezdiffra, which is the name we're going to use on this podcast from here on forward, to become the first drug specifically approved for treatment of, well, they approved it for NASH, but the FDA says NASH and MASH are interchangeable, so we're going to use MASH, at least for now, because of who our audience is. I think, frankly, we've talked about this a couple of times on the podcast. The term to use and the audience you're speaking to have a lot to do with each other. And when we did our nomenclature episode a month ago, even the nomenclature people agreed that when talking to a patient, people are going to say, hey, there's fat on your liver. So that isn't going to go away. But at any rate, whatever you want to call it, it's been approved. And we are now in day 4 of post-launch euphoria. As you folks know, we did an episode on Friday with global key opinion leaders and Louise and Jorn, and we asked Jeff to join us because we wanted one person who wasn't a key opinion leader and was well-informed. And it's fun working with Jeff because, as these guests have noted, his lips don't move while he talks on the camera of the podcast. So with that, we have a fantastic cast of characters with us today. I'll just start by saying hi to Jeff again. How was your weekend?
It was lovely, Roger. You make me want to, wouldn't translate well for podcasting, but I feel like I need to do the liver through interpretive dance so you guys can see everything appropriately here. Lovely weekend. It's warm. Cherry blossoms are at peak in Washington, and it's just a great time of year to be in D.C.
I'm going to keep going to my left. Louise, how are you today?
I'm very well, thank you very much, and great to see the big guns of patient advocacy all in one spot at the same time from the US and Canada.
And then to Louise's left on my screen is our newer but good friend Jen Jones in Colorado. How are you doing today, Jen?
I'm doing great. I'm doing doing wonderful because the snow has melted from last week when I had about 13 inches on the ground. So much better day today.
Congratulations. And going straight up from Jen, we've got Mike Battelle. Mike, how are you today?
Yeah, everything's good except Jen. We had a little snow today, so I don't know what happened. It was a really easy winter in Toronto, but it just keeps coming, a little bit at a time. All's good, bro. Very happy about the announcement too. Sorry about that, Roger.
That's right. I was just going to say that, trying to remind you not to get cocky about the weather, but you knew that already.
Yeah.
And then to Mike's right on my screen, we have Tony Vigliotti. Tony, good afternoon.
Yeah, good to see you. Everything is going great here in Pittsburgh. Cold day today, but we had 70s last week.
It's cold in Philadelphia also. We had 70s last week also. Finally, upper right-hand corner, we have Wayne Eskridge, who looks like himself, which is a good thing. Wayne, how are you today?
Well, I'm good. Out here in Idaho, we're having beautiful blue sky days and 60 plus degrees. It's great to see spring coming.
Yeah, it is. And we all had that last week, and hopefully we'll have it again next week. At least Tony and I will. And Jeff's got it now. So just to start quickly before we do Groundbreakers, everybody knows what happened Thursday because we've mentioned it a couple of times on this podcast already. On Friday, we had a bunch of global key opinion leaders on talking about what they thought the impact would be in terms of patient treatment and what important next steps are. And today we wanted to see the patient and patient advocate point of view on exactly that question. So I was fortunate enough to be able to gather up most of my favorite patient advocates all at the same time, all in the same place, at least in the same computer screen. And away we go. Let's start with Groundbreakers. Everybody, one good thing that happened in the last week that is not the Rezdiffra approval or the weather. Brave one, go first.
Oh, well, I probably have the most dramatic one, I suppose, perhaps. Most of the people in the field know that I went through a myeloma crisis last summer. Had a number of spinal compression fractures. And yesterday was the first day that I actually got back out on the green belt, and I'm recovering well. And so it was a glorious experience after almost a year of recovery.
So for those in all these countries that don't know Idaho real well, what exactly is the green belt? And when you say you got out on it, what did you do?
Yeah, well, here in Boise, we have an extensive path system for bikers and walkers, which goes through the city and along the river. So it's a very pleasant place to go out and commune with people and nature and get a little exercise.
Congratulations. And when I said at the beginning that someone who looks like the old Wayne Eskridge, that's what I was referring to. And you look great. You look great. Glad to have you with us.
I feel great. The best I've felt in a year. So this is great.
Bravo, my friend. Bravo. Next.
Well, the highlight of my week is this is the 6th anniversary of my liver transplant. So kind of celebrating that.
Oh, wow.
Yeah, unfortunately, we're going to celebrate by eating all the foods I ate to get a fatty liver. Other than that, things are going great.
Well, it's good that you could do that, number one. And number two is they say that the first thing that happens when a drug gets approved is everybody gets casual about their diet. So don't let that be you. Just make this a one-off. Okay, next.
So we just confirmed that we're as in Fatty Liver Alliance, going to be hosting a Medscape reception at DDW on the Friday. So that's really exciting because we've never done anything like that before. And it's, if anybody wants to get invited, or you can write Michael at fattyliver.ca. I can get you an invitation. Thank you.
I know your personal email. I could do better than that, but go ahead.
I might let you in. I might let you in.
Next.
Oh, I guess I will go, but mine had to do with the weather, so you totally took mine away. Getting 13 inches of snow is probably one of the biggest events we've had here for many years. We haven't had this much snow. And my good news was, our electricity will go out for no reason at all, it seems. Many times my internet will fail, but I had full-on internet, electricity, everything all throughout the entire snowstorm. So I will include the weather this time because I was able to keep working on sober livers, which is so important right now. And so I was able to keep up on my work.
That's excellent.
Yeah.
Okay. And for that reason, it wasn't just about the weather, so that's fine. Jeff or Louise, brave one, go next.
Well, I gave an update on Friday, Roger, so you're kind of asking for a 2-for-1 here on this.
I'm doing the same with Louise. You're absolutely right. Go ahead.
For both of us, I guess, for both of us. And I didn't see how Liverpool did over the weekend, so I can't step on Louise's toes for that.
Jeff, what you could have done is said, I'm delighted that my two really good friends, both of whom follow Premier League, had their teams get totally kicked in the body part of your choice over the weekend. We were dreadful, and then they were as bad. So
I will go the opposite direction and do something very American here then, and that is that it was such a busy week. As I said on Friday's episode, we're thrilled that we actually got 2 liver drugs across the line, one for rare disease for pruritus, and then obviously with the big NASH news as well. So thrilled with that, and a big rush of media and of answering patient questions and regrouping, all to lead to my ability to get a quick cycle around the cherry blossoms downtown, and then some downtime where I was actually actually able to do one of my favorite things, which is just lay on the sofa for a couple hours and watch the NASCAR race out of Bristol, which ended up being a great race in Tennessee that day. So it's not quite Premier League, but it speaks to my roots. And it was nice to have a couple hours for that.
You take the boy out of the South, can't take the South out of the boy. Absolutely. Louise?
Yeah, like Jeff, 2 for 1. I suppose for me, it was the fact that I've been given the all clear to fly to Canada on Thursday. I had a skiing accident last week, and although it's curtailed my skiing, it means I get to learn a bit more about Whistler and Vancouver, which, because I normally ski, means that I get to do something different this time. But it's nice to be able to fly on a family holiday because it's the Easter period and stuff. So this was already planned. So fingers crossed.
Yeah, I know you were concerned about that. That's great. So having had to put out a podcast episode over the weekend, which I don't usually have to do, but we recorded one on Friday, and having to get organized for this, which is also going out on a slightly expedited schedule, I had time to do one of my favorite things, which is go bowling with my granddaughter. Now, of course, she gets bumpers, and she gets, they've got these things now where you put the ball on the top of the slide and push the ball down the slide, and it actually goes. But she doesn't like to do that. Instead, she just likes to take it between her legs and throw it down the aisle. Usually it goes up in the air, it lands on the ground about 10 feet down the aisle. I keep thinking these bowling alley people must be shuddering every time they hear boom, but she's probably not the only 6-year-old who ever does that. So, and they've got virtual reality games there. So she and I, we bowl, we do virtual reality games. It's just a great time. All right. With that, why don't we go forward? Okay. I'm going to start this where I started the Friday session, which means, Jeff, and you don't have to do the whole story in detail. You can do a different one if you want to. But so tell us about your Thursday, right? How was your morning? How did the day go for you? And then what happened after you actually found out that for whatever it was in the afternoon, the drug had been approved? Brave one, go first.
My day, we're out here in the West. Our time zone is a couple hours behind you guys. So it was late in the day by the time we actually got the information. Yeah, well, there were a lot of people asking me questions. Have we heard anything yet? So, it came out pretty much as we thought, but it was still kind of a nervous time. And there was a lot of interest of people just wondering, what was happening. So it was a good day. I really enjoyed it.
I will go. I didn't know I had OCD until I kept hitting refresh every 5 minutes to try to find out what was happening. So I was on the Madrigal Twitter site really checking. And then what surprised me was an announcement that said that ASLD had posted this premature announcement and that they pulled it. And of course, the stock went down and it's like, oh no, like what is something going to happen? I go, no, can be confident here, and just kept hitting refresh until the good news was shared. And then I spent the next few hours posting on LinkedIn and Twitter and writing all my physician friends and letting them know on the board and Canash we work with. So great, busy day.
So Mike was the person who alerted me to the idea the stock had gone down in the wake of the ASLD announcement. I don't buy individual stocks from drug companies. It's a policy I made when I was doing drug pricing because everything I knew was disclosed, and I've just never gotten out of that habit. But it did go up 22% in the aftermarket. So if you jumped on it when it was 5% down in the day, you could have sold it the next day and made a killing, virtual killing.
Yeah. I also spent my entire day sitting in front of my computer. And where I elected to sit was, even though I don't own any Madrigal stock, I was on a Yahoo message board for Madrigal stock. So I was following the path of pricing and also a lot of interesting comments from people who do own a stock about what was going on and, why did the stock drop? And, a lot of talk about the AASLD premature announcement. And I was hopeful, but a little apprehensive that it was taking so long because in the back of my mind, I still wasn't convinced the FDA was going to do the right thing. So until that time came when it became official, it was a tense day for me.
Wayne or Jen, either one.
So I was very similar. It was the day of the storm. So first of all, I was already hunkered in. So it was like a perfect day for me to just press, refresh. I was really looking for Henry, who is our executive director of the Fatty Liver Foundation, to send out the notice. And we got it. And then I was like, because I knew I was tasked to then get on social media and start sharing social media about this wonderful announcement, to which I did it as soon as possible. But it was really a magical event because we got to see a lot of Wayne and a lot of his quotes and those types of things. So I was very honored to be a part of Fatty Liver Foundation as sober livers in that day.
Yeah, Wayne, you were kind of the poster boy for the announcement, right?
Yeah, I was in the press release, and it seemed like...
Now, you didn't get a slide like Terry Milton did, but you were in the press release.
Yeah, I got a surprising number of pickups around through the various press. So that was fun. I had a few interviews, which was cool.
I will say this about my experience. I didn't say this on Friday. That first of all, I spent the day on sitting on FDA.gov because they were going to put it out first and they were going to put out the label with it. And that was what I wanted to see. But the more I read the label, the bigger my smile got because I really liked the label. And we talked about that a little bit on Friday. We'll talk about it a bunch today. In fact, as I was hitting refresh on FDA.gov, that wasn't the first place I found out about it. Before my computer could refresh fast enough, Mike Patel sent me a note saying they announced. So he was right in that 30-second window. For those who think that Mike is not always everywhere and at the right time, this is really impressive. Really impressive. Okay, Jeff, Louise, you went through this on Friday, but you got anything you want to add for people who might not be listening on Friday or added details?
For me, it was about the realization that this wasn't only a good day for patients with currently who have metabolic steatotic liver disease, MASH, F2, F3, but for the community yet to be diagnosed and to be located, but also what it does for the profile of poor liver health within other disease spaces, endocrinology, cardiology, and what it could mean for the location of other liver problems, rare diseases, things like that, where we start looking and we find an issue, we then investigate the issue. So drilling down. So it wasn't just how much this will change the world that we live in with MASH and MASLD, but how it will influence future liver disease care location because of its non-invasive aspect in the label.
Yeah, the only thing I would add to that, Roger, is that we were more than cautiously optimistic about this. I think refresh is the word of the day when it comes to talking about the experience there. We were doing the same thing, and it's certainly not our first experience with a regulatory agency waiting until late in the day to announce something. And so we felt we weren't sweating it that much for that reason. The number of times that I've experienced a release or a rulemaking or something from a federal agency at 4:55 p.m. on a Friday afternoon, I'd be a rich man if I had a nickel for every time. And so we were still feeling pretty confident around that. But as the 4 o'clock hour rolled around, we got our team together on a Zoom meeting and had the GLI group there all kind of tracking different social media and the websites that were appropriate. And we actually saw the labeling before we saw the announcement that came forward. The PDF got posted. And so that gave us some thought. After the ASLD shenanigans earlier in the day, it made us worry a little bit that there was something misdirected going on. But we knew once we saw that label that things were headed in the correct direction.
It's funny. I wasn't concerned about what happened with ASLD because, as Jeff knows, Louise does also, we scheduled an episode for 2 o'clock on Thursday afternoon because we had 1 or 2 KOLs that could join us on Thursday, but not Friday. And when I talked to Jeff about that, he started laughing at me, as he's doing now, again, saying, you think this is going to happen early enough in the day to do a 2 o'clock episode? I said, well, if I can't, we'll get rid of it, and you and someone else will push back to Friday, and everyone else we just can't get. But Jeff had it right. I decided that 4:15 was about the time I'd start worrying. Yes, I was hitting refresh all day, but not with concern, just kind of prurient interest. So I'm struck by the idea that right now, of the 7 people here, we have 3 MASH patients, 1 other liver patient, and 3 non-patients. So I want to ask the patients first to talk personally. As a patient, what did it mean to you to see this thing finally cross the finish line? I'll get back to as an advocate in a minute, but just in terms of personal experiences, what did it feel like? What did it say to you?
Well, it brought back a lot of memories. I go back in my course to 2014, 15, and one of the defining moments of my life really has been when the doctor said, you have NASH, and I'm sorry, we have no treatments. So it brought those feelings back. That was a very emotional event in his office that day because I had just enough information to say, well, that's a terminal illness problem. But having a therapy that, even if I can't get it, of course, since I'm an F4. I wouldn't qualify for the drug, but I can really appreciate the value that will have to the future patient pool. It's a different atmosphere when you at least have some options to think about.
In my situation, as my disease progressed, I was never aware that I had F1, F2, or F3. I jumped right from fatty liver disease to F4 as far as I was aware. So it didn't have any really direct relevance to my particular situation. But just the hope that this drug brings is what really struck me. Even though the drug as it sits will only affect about 300,000 or so people, I think it just improves the mindset of everyone that's battling disease and introduces a sense of optimism that even if this particular drug does not help you, this approval kind of shows the way to what can happen in the future. So I felt kind of exhilarated, relieved that it was after so many years of following this stuff, that it finally happened. In a sense, it was like, sometimes you get the feeling that it's never going to happen. So once it actually did happen, even though it was a high level of optimism it did bring a sense of exhilaration to me.
Well, I am not and have not been a NASH patient. I had a steatotic score that was like S3. So I was a fatty liver patient and was able to clear that. But as we all know, it can come back at any time if you don't do some of the right things. But I agree with what Tony said, especially the comment about hope, that for patients that do progress, especially quickly, which can happen at the later stages, that there is something that they can now take and without a biopsy on top of that. So it's, less invasive and much easier for them to have access to than in the past. So it's great news.
Okay. And Jen, I know you're not a steatotic liver disease patient, but you're a liver disease patient. I was wondering how it struck you.
It all starts with steatotic liver disease.
Yeah, it's true. It does. Just comes from different forms.
I was diagnosed with fatty liver in 2013, but at the time they said, just drink less. And that's the normal spiel that they give: drink less, lose weight, whatever it may be. And in 2018 is when I was diagnosed with alcohol-associated cirrhosis, which was decompensated, and alcohol-induced hepatitis. And so at the time, all they could tell me to do was to stop drinking. And they gave me a handful of diuretics to take and, other types of supplements. But that's all that they could do for me. And I know for people that were in the situation of MASLD and MASH, that they're facing the same thing. It was lifestyle changes and, you just have to go change your diet, and you weren't given any really good help. I think this treatment opens the doors a couple of reasons. I really like how on the label it says that it should be used in conjunction with diet and lifestyle change. I really do like that. I love the fact that it's non-invasive. And I also love the fact that this opens the doors. Think about like diabetes too, and think about the number of drugs from 1982 when insulin came on board. I just took a look and there's 59 drugs now on the market since 1982 for diabetes too. Well, I could foresee the same thing happening with steatotic liver disease across the spectrum. And this is just one door opening. It's going to help a lot of patients, but as the usage increases and we see how it works in other patients, I believe that this is the start of a new day. It's a new era for us. So I'm super excited for everyone.
That's great. Couldn't agree more. I had an experience on Sunday that put all this in kind of a different context for me, which is I have a good friend who's gravely ill with pulmonary fibrosis, for which there is no cure. And Wayne, hearkening back to your initial comment, fibrosis is tough. Fibrosis is really tough. And I was talking to his partner on Sunday, and, the hopelessness is really devastating, and you can be brave and you can have good days, but you have bad days. And this friend is significantly down the path, and realizing that for so many years, right, that was all that liver patients had to look forward to, and that this might be different now. I couldn't help but connect the two in my mind and wonder, just connect the two in my mind, leave it there. So I've heard the number 300,000 to 400,000 a couple of times. My impression is that there are more F2s and F3s in America than simply that many. So where does the number come from? Please to explain to our audience. I mean, Jeff's used it with me. Tony uses it just right now. Where the number comes from and what is the next population? Because going back to Jen's point, the population of treatable patients is broader than that, or should be broader than that for a drug like this once the system's in place to handle it. So where does the number come from and who does it leave out that might be included or thought of more expansively over time?
I'll jump on that answer, Roger. For me, that number comes from an estimate of patients in the system right now. And so when we look at patients in the system, probably, looking, as you said, F2, F3, that's currently diagnosed in the system and theoretically receiving some sort of care of some sort for some sort of additions. That's going to be very different than kind of what I see the next step as being, as working with providers to identify patients. Because I think that there's a larger group that has this, as you say, it's going to be way over that number, but that have not been identified. And I think that there are places where now that's part of where the hope comes from, is now we can start that process to identify, to better categorize, and be able to get them medication and treatment that's going to be helpful in this way.
Okay, that makes perfect sense. I mean, when they talk about, a lot of times first drug gets approved for a disease, they talk about patients that are warehoused. Would this be analogous to what you would describe as a warehouse patient population? Or is it, since there was nothing to do, everybody that has this disease and is in the system, we know how to track?
Yeah, that's a harsh term for me, because I feel like there's so many co-occurring disorders that happen with this, and the symptomology is so complex. The notion that the patients are being warehoused kind of indicates that they're just being put aside for the moment, and I don't think that is the case. I think what we've got are patients with, when we look at this disease state, F3 to F4 can be kind of fuzzy. So how do you get the treatment there for that? When does that moment of fibrosis occur? F1 into F2 equally can be kind of fuzzy. I mean, we're not talking about black and white states in this way. And so warehousing sounds a little harsh to me in that regard, because I do think that with patients that are identified that are in the healthcare system right now, that's largely because they are receiving some sort of treatment. They have been identified and or maybe going through clinical trials, as a means of hope for trying to address this. They are probably struggling or trying to attempt some sort of behavioral change with physical activity and nutrition. And so I think this is where the true hope comes in this, is that it allows for the ability to now take a next step in something to address, the specific stage of NASH, while also, as Jen said, doing it in conjunction with, as the label indicates, the other treatments that they're already engaged with.
Yeah, question for Jeff. Maybe he knows, or someone else knows here too. Patients that may have received the placebo but not the active drug in another study, or patients that had an active drug that didn't respond, that might be included in there as well, right? Would that be included? Would that number be included as part of the number that Roger was quoting?
I believe that to be the case, yes.
I suspect that's right, Mike.
I think the figures were shown by Madrigal at the press conference come from because I've pulled it up here, the Forian claims data, and it was presented 7th to 10th of May 2023, Boston. And it showed a diagram that basically filters in of 1.5 million people diagnosed with NASH. Diagnosed with NASH moderate to advanced fibrosis was the 525,000. And further down, there were 315,000 diagnosed moderate to advanced disease and seen by the 14,000 specialists. So they demonstrated that quite well. And I think that accounts for everybody, because you can't cherry pick out of that who's been enrolled to a study, who's not been included, who's not. So to answer that question, Michael, it never demonstrates who's already been treated within a clinical trial. But I think the term warehousing, I would agree with Jeff. It was something that was coined in the hepatitis C era, particularly for the direct antivirals. And that was because there was a treatment that was worse in the context of long-term side effects. We did not want to start genotype 1s or 4s on a year's worth of treatment coming into the approvals for, obviously, Gilead at that time. That was a patient choice. If the patient still wished to carry on to go for interferon therapies, because we were strong believers, right place, right drug, right time, the patient decides that. But a lot of patients held off. And that's where the term that I'm particularly familiar with, warehousing, comes from, because we had a better advantage coming. So I don't think that's the case here. I think there was nothing there. We have to manage comorbid conditions. And we know a lot of patients with NASH are not optimized on their comorbidity conditions and medications. And I think we can still strengthen that. We still need to strengthen that in light of resmetirom approval.
So thank you. I got that question about warehousing 3 times between Thursday and today and didn't have a really good answer for it. I too, I know it came from Hep C. So I just figured I'd throw it out to you guys. One of you guys would to help me look smarter the next time the question showed up. And I think you've done a really good job of that. So we know what it feels like as patients. How does it change the work of advocates? I mean, Wayne, you put out a letter on this today about things that Madrigal were doing and how to collaborate with them. I'd love for you to take a minute and share with our audience, most of which probably doesn't read your newsletter or your personal letters, about kind of what you were talking about. And then, by the way, how they can find you so that they can stay informed, because I think what you put out every week is really good.
Well, thanks, Roger. We've collaborated a fair amount with Madrigal over the years. There's a goal on their part, I believe, and it's genuine, to really deliver excellent patient support and patient care and access to the drug longer term. And as part of that, they've developed a patient support portal, which that's something that a lot of firms produce, but ordinarily those are links to PDF files and, some links to additional services that people can find. The thing that Madrigal is doing is they're actually building a staff which is charged with helping patients solve the problems of access that they have. So in theory, if someone is unable to get the prescription, or they're unable to deal with their payers, or they're unable to find financial support, that this staff will assist the patient directly and assist them as more like navigators for liver transplant, perhaps, and not just as a portal for PDF information. And we really salute that, because as we go into this whole process, it's a complex thing, and it's going to be very easy for patients to become confused and misdirected and feel stymied as to what's available and what's not. So I really commend Madrigal for that. And, if people want to follow up with us, go to the fattyliverfoundation.org and just give us your email, and we'll keep you on the mailing list for our blogs.
Okay, great. Anybody, anything to add on that point? And then I have a bunch of questions. Actually, I have more questions I know what to do with, but go ahead, Jeff.
I've got one thing on the patient advocacy specifically that I want to speak to, and I made this point on Friday, so forgive the redundancy, but I hope the emphasis is heard by this group and then those that may be listening to the show as well. If we go back in the timeline to when Intercept was turned down by the FDA, you remember that there was a revision to the endpoints that the FDA was looking for. It wasn't just NASH, but it was NASH with cirrhosis. It was very specifically indicated for this. And now in this, we've seen that it is the language you're using is non-cirrhotic NASH for the labeling on this as well. And in between these two events, GLI worked with, I think, most of the folks here on the call today of patient advocates, of liver patient advocates, to talk to the FDA about things such as what their endpoints for and considerations around safety were, what the efficacy considerations were. That we wanted to make sure that this wasn't just kind of a purely scientific engagement, but that patient concerns were being heard and were being responded to by the agency that is charged with approval and consideration and helping approve the drugs so they can go to market to be able to help support the folks on this call as well as others in the world as well. What that tells me is that patient advocacy, GLI, we did an externally led patient-focused drug development meeting soon thereafter that took a lot of these issues about the non-invasives, about biopsy, about the safety protocol, about pruritus, about all these things that were being considered. And we made sure that the patient voice was heard, was loud, was clear on this. And so when we've seen the announcement come out from Madrigal and the FDA on a positive outcome for this, what that tells me is really reaffirming. And it is that what occurred is patient advocacy has made it safe and indeed has even made it profitable for investment in liver health through effective liver health advocacy. And that's where so often we're pushed with, liver patient advocacy being just about kind of getting better care for patients. But the 30,000 foot on this is because of the advocacy that the individuals on this call did and GLI did, is that this is where the hope can come from, is now we have proven it is a safe place. It's even a profitable place for investment into liver health. So we can now have future medications, future treatments, and better clinical trials coming forward to better be able to address the needs of every patient at every stage of liver disease.
I would second that. It was a lot of activity by the patient groups about biopsy, because that was a very serious concern for a long time, and we railed about that. We really made our opinions about that visible to FDA, and as a group, as the patient advocacy community was, I think, instrumental in the fact that this label does not have biopsy. And I think that's a huge step forward for the patients.
Absolutely. I think just standing on my end, just looking at the future of medications and the future of clinical trials, especially, I think we're going to be going in this direction of non-invasive ways of measuring to determine whether or not a person is at a certain level. And I, for one, am all for it because I've had a biopsy and I know what it feels like. But for a patient who is doing this, to obtain a drug, it for some people, it's not accessible and it's hard to do. So I think we're making the accessibility a lot better too.
Just my 2 cents, and I just want to echo what Jeff and Jen said. When I walked away from the public input hearing for the Intercept drug, I thought the FDA was very dismissive of the patient voice in that proceeding. So I was very pleasantly surprised, and I've, give credit, a lot of credit to GLI and to others on this call, that, the final labeling that was produced by the FDA, I thought was much more insightful than I might otherwise have expected. You're recognizing that you don't need a liver biopsy to get the drug and just giving physicians, some latitude, recognizing that the F1, F2, F3 thing are not necessarily bright lines. So, giving the physicians the latitude to use their judgment and, in terms of who to prescribe the drug to. But I have to give the FDA a lot of credit for basically changing their view of considering the patient voice.
I wanted to take a moment too, it's a perfect segue from Tony's comment, and represent the Liver Action Network under the GLI. I chair, there's 14 organizations, Tony, Wayne, and Jen are all part of that. And we speak a lot. We did speak a lot, with regard to ICER and the FDA, and we're going to continue to work together and being aligned with how we can synergize and make a difference in the, in the world of patients, by focusing on that unified patient voice.
I'm going to chip in now because I think they've all been fantastic comments, but I'm going to just follow up on Wayne's comment about the support that Madrigal are giving here. And this could be a game changer moving forward for medications prescribed and approved for patients for liver disease. These patients and people with these conditions have multiple other conditions. It is very, very difficult to navigate the current healthcare system in any country. And in fact, any assistance that can be given. Now, they're given educational resources. They've pledged coverage navigation, as Wayne was discussing, financial support, direct-to-patient delivery, and patients with no insurance or no coverage for Rezdiffra may be eligible to receive medications for free. And I think that type of support in complicated comorbid disease structures is not just something that's unique to liver disease, but would be very welcome in all complex diseases where you're navigating type 2 diabetes or cardiovascular disease appointments alongside all of these other appointments. It's just not one condition. The more assistance that companies can provide, the better. I have to say I've never seen patient advocacy to remove things like biopsy achieved in such a way. So Jeff, Michael, Tony, Wayne, Jen, everybody else, I totally agree. I think it has made a big difference in what's occurred in the last 3-4 days, really.
Agreed, and kudos. And to add one thought, there are things I listen for, and a phrase I listen for and don't hear often enough when talking about new drugs is medical exception. For those who don't know exactly how that works, if you have a market access problem with a private insurer, the easiest way to get a drug before it's been through formulary review is to make a case for medical exception. But no one ever talks about that. And I have a friend actually who works in oncology who says they're asked all the time by CEOs, particularly of smaller companies, about market access, and nobody ever understands that one until they're 3 months out from market, and then it's too late to do anything. The specific phrase medical exception was mentioned by Bill Siebold as one of the things they were going to work on in the press conference on Thursday. And for me, that was a sit up and take attention moment, because it said, these guys are really serious. They've really thought about it. And to go back to Louise's point, I think that will have a benefit for everybody who ever wants to take a new diabetes drug or the later drugs that come down the pathway here, because they will tread that path and other people will know where to follow and how to follow. And you don't see that other vision in a whole bunch of other diseases, and certainly not this early in the game. So I thought that was really impressive. So what next, folks? How's this going to change what any of you are going to do starting tomorrow?
It raises an entirely new field of education and outreach. One of the problems we have had historically is because there was nothing to say other than be supportive. It was very difficult in engaging with the patient community because these are largely sick people that are just desperate for something. And a lot of times we just end up being sympathetic and holding their hand and letting people know that we're there. But this allows us to change the nature of the dialogue, I think. And it's not that everybody's going to be able to get the drug, Like I said, I can't get it because I'm an F4. But it still changes the flavor of the kinds of things that we can communicate to the patient community. And I think that gives us as advocates an opportunity to refresh our messages and have broader perspectives and have more hopeful outlook to the future, because it really does give us the springboard from which we can talk about the other drugs coming down the line. It gives us good ammunition to encourage people to participate in the new clinical trials that are coming along. Our access to the pharma companies that are building things should improve, because hopefully they see the value that patient advocacy has brought to this event. And the investor community, I've been kind of surprised. I've had a couple of calls from investor groups that were curious as to, from a patient perspective, what did we think about this drug? And this is going to, it just creates a more fertile environment for us in terms of the kinds of things that we can talk about and use as ways to educate the population and the doctors. We participate in some CME things for docs. When they get past this 315,000, and they start to really try to educate the primary care docs and that broader field, there's going to be a lot of activity that takes place because of this. And, that's going to benefit the patient advocate community, because they're going to want us to help them. If we talk about it well as we go through the next year, the industry should develop a more robust appreciation for the value that patient advocates bring to the party.
Everyone's nodding. Jeff, you looked like you wanted to say something a minute ago, but I might have misread your face, because sometimes your face is slower than your mind on the screen.
Oh, boy, isn't that the story of my life?
That's not good.
It just means you need faster bandwidth, my friend. Go ahead.
Roger, we got a face made for podcast here. Thank you, sir. I'm just kind of acknowledging, the truth in what Wayne is saying, and kind of thinking of, he's given great examples here as a NASH patient, and it's interesting to me because I think Wayne as an F4 patient doesn't have access to this drug right now. And so does that mean that in the future that an F4 patient wouldn't have access to this drug? It means now that we have approval, now these are the sort of questions we can begin to ask. We can start asking questions around dosage. We can start asking questions about reimbursement. I mean, there's incredible precedents that have been set here, but I think, it also allows patients now to move to the next level of inquiry in terms of, okay, what's next? Let's talk about progress. It's not just kind of this metaphysical sort of hope for things that will happen, but we've got real tangible things now that we can attach questions to get hopefully some really great deliverables off of. And so it's mostly just nodding in agreement with where Wayne is.
You collectively all are raising an interesting question, or at least I'm taking an interesting question from this, or a question I think is interesting. I'll keep stepping back until I completely minimize. But, one of the metaphors, one of the visualizations I always have for disease, and particularly this disease, is if you want to stop the flow of patients into a disease where incidence is growing rapidly, it's a little bit like trying to put your foot on a hose. Right? You can't stop what's in the hose already, but maybe you can lessen what gets into the hose. So here you can see that working two or three ways, which is, will the number of patients coming into F2 and F3, will enough of them be treated so that fewer people will get to cirrhosis? I mean, one possibility is we'll treat, but the rate of people coming in will outstrip our ability to treat, and as a result, cirrhosis will still grow, but more slowly. Second one is we're going to be able to treat enough people that there will be less cirrhosis 5 years from now, picking a date, point in time. Similar question about work advocates have been advocating for patients, but the largest patient population right now are the untreated, right? In fact, the undiagnosed. So I'm wondering how you folks see the work that your different organizations do in terms of helping find a path for the undiagnosed to become diagnosed, because if you really want to put a foot on the fire hose, that's where the foot's got to be. So is that in anybody's plans, and what are you doing to do that now?
Yeah, that certainly impacts us, because most of what we do is working with that untreated population. I mean, we go out and talk with the general public about liver health, about fatty liver disease, and so forth. And 99% of the people we talk to are not in the treated population. And for that population, it won't affect a whole lot of what we talk about, in the sense that, they're not to the point where they need to start talking about a drug. I mean, they just need to be aware if they're at risk, and we try to drive them to increase their awareness of their liver, how to keep it healthy, what the actions they're taking that are negatively impacting their liver. And then if they are at risk, encourage them to get into the healthcare system. So that's kind of the population that most of what we do is actually aimed at. I mean, we start with the children, just trying to impress upon them, the importance of good liver health, hoping that also extends into the adults in the family as well. We do talk to patients, provide resources. We run a support group, and, we'll certainly have the same issues that others do in providing information and guidance as to how to get into to Madrigal with those people. But a lot of what we do is working with that untreated population.
So Jen, your work's a little different in some ways. How does the untreated population relate to what you do, and to what degree is liver awareness a key to what you do with that population?
Well, I was having some thoughts about this as Tony was talking, and Jeff and Wayne, and I was listening to them, and I thought I had, number one, outside of sober livers and some of the work that we want to do is, and when Rezdiffra, if they decide to advertise or start putting it out there, and people realize that there is a drug on the market for liver disease, my idea is that people are going to start asking their doctors to find out if they have liver disease, where they didn't do that before, because there's something that may be able to be done for them, regardless if they find out they just have steatotic liver disease. Well, guess what? We're catching it in a time where you don't need a drug yet. You can make some lifestyle adjustments, and we can work on this individually. And I foresee this as being a good opportunity for people to become more aware of liver disease itself. And then secondly, for the population that I'm working with, which includes a new category of MASLD, I really could see this expansion of this drug easily falling into this group. And if you look at who possibly may come into this group, when I'm looking at numbers of people with alcohol-associated liver disease, and I'm looking at diabetes and obesity information with this group, it's hitting around 70-75%. So you better believe a lot of people who have been diagnosed with alcohol-associated liver disease actually will be in this category. And I see this as a natural pathway for this drug as being one of the easier ones for it to go to next. So educating the community about this, when we're having our virtual groups, when I'm doing other types of promotional efforts for liver health, and helping people to realize, let's figure out where you're at. Let's know where your liver is. And I think that's going to be key. And I just think just having this in our back pocket as a tool, saying, look, there's something out there. So let's get you tested. I'm all about early detection, especially with alcohol-associated liver disease, because that can put you in treatment. And then the other thing I will say, because I find I'll bring it back to having it in conjunction with lifestyle changes and diet changes. I take medication for anxiety. I take medication for depression, and nowhere on that label does it say I should use in conjunction with therapy. And I think that this really does open the doors for the FDA to think about this in a more broader picture of what we can promote to really treat some of these other comorbid conditions that are out there, or concurrent conditions.
Hey, Jen, that's fantastic. I'm old enough that I never hear a truly original thought anymore, but that was one. Thank you very much for that. That's great. Other thoughts?
I am going to pitch in slightly here. I get slightly fed up with the excuse that people give of overwhelming the system. We would have to change the system very drastically, very quickly to overwhelm it. What we need to do is start pushing the needle to build the capacity in the system. And the health services respond to need. If there is no need, I have no reason to apply for an increased budget. If I have no need driving my service, it is a threat. Our services are taken up with 94% of people who referred with abnormal liver function tests, who we refer straight back to primary care when they get non-invasive testing like FibroScan. They are blocking the system and preventing capacity. So we need to reframe is it that we're scared of overwhelming the system, or is that just an obstruction to not building capacity into the system to account for changes in liver disease care and adding associates, adding more nurse specialists. So I think we need to reframe a few of the questions, and we need to ask ourselves, why are we overwhelming the system? Because that would take a number of years to do, and we've got a number of years then to adapt our system not to be overwhelmed. It's one of the reasons that I left, to build a service that provides direct into the system with a better level of knowledge and diagnosis and early access to non-invasive treatments, because we do not have the capacity in any country that I've seen so far to give non-invasive tests, whether it's ultrasound elastography, 2D shear wave, whether it's PET scan, MRI, PDFF. We don't have that capacity in any location.
Okay. Well, I wanted to follow up on Louise's point that she just made and to give two other examples. So although we do have educational events for patients who already know that they have MASLD and MASH that are almost finished and ready to launch, three other areas are we're going to be actually doing, Louise, market research across Canada, almost 27,000 primary care physicians to find out what challenges they're having with regard to access to non-invasive testing. Yeah, it's going to be really, really big. So it's just going through ethics right now. And so that's one big one. For Global Fatty Liver Day that's coming up on June 13th, Jeff, we're actually doing a in-community educational event. So we are talking to patients directly, educating them and offering FibroScan assessments, liver health assessments also. There was a liver conference in Canada, and we actually had a FibroScan assessment done and did 104 scans. So we put that data together, and we're going to be sharing that as well. But the point is, we were trying to educate GIs, because it was a liver conference, general liver conference, on what a FibroScan even is and why it's important to assess. And some of them had never even seen one before. So that's why it's important to educate sort of all aspects for liver care.
I think that makes sense. Here's my controversial moment. Louise, I want to come back at what you just said, which is that in governmentally run health systems, the decision to invest is made in the public good. In the States, it doesn't work that way. So right now, we're not going to get more doctors or more anything simply because we know there's a need until people can figure out how to manage the economics of the need. You heard this from Naeem a couple of weeks ago. We heard a little bit from Zobair on Friday, where this need is primary care doesn't have time to integrate this into what they're doing right now and don't know how. So once we step outside the 315 patients, or maybe the 500,000 patients that are one level out from there, we get to a place where we have to rely on non-specialists or non-gastro-heps even to do a significant amount of screening and frontline treatment. They don't have the schedule, they don't have the budget, they don't have the training. And unlike or Canada, where maybe your resources are scarcer, but if you decide it's what you want to do, you can get it done. Here, there's no obvious way to do that. So when people talk about overwhelming the system, I think that's a different phenomenon in the States than it is in other countries. But it's going to be a tougher one to deal with here because the roadblocks are more and differently entrenched. Jeff, do I have that right? I see you nodding.
Yeah, I think it's really interesting because it takes me back to COVID. I mean, that was in the U.S., that was why everybody, aside of spread of transmission, but that was one of the factors cited with COVID, was everyone stay home because we were overwhelming the system at that point. And the hospitals were overwhelmed and, the care was overwhelmed. Granted, this is a little bit different, but I think for me, Louise's point is well taken, because we tend to get kind of locked into a mentality of don't burden the healthcare provider anymore. And I would hate for that to be the case in this, because we do need to figure out solutions so healthcare providers can step up in a way. And one of the populations that's been left out of the conversation in this on the American side has been U.S. veterans and the Veterans Administration. And we know, for instance, one of the places that we can make an improvement is getting what's called a smart phrase. It's part of their EHR, but getting that put into their electronic system. So now we can treat the veteran, engage the veteran system as well. And in doing so, I think we kind of feed two birds with one stone, one seed here, if you will, which is that, we're able to enlarge the capacity of the healthcare system, because now we've brought the VA in intentionally. And this is from patient advocacy. We've done this, brought the VA in, worked with them to be able to include that population. Obviously, we've got private insurance we need to work with. We know often in the U.S. they'll follow Medicare and Medicaid. Then we also will have the individual states we can work with. So there is a ton of work to be done here still, which we have been held up from doing because we haven't had a medication that's been approved from the FDA.
Right.
So now we can start all that sort of stuff. And hopefully by the time that we get to implementation of a lot of those things that we need with the VA and state Medicaid and all these other things, we will have begun to get another medication through the system. We will begin to be able to look at, maybe we can talk about off-label stuff. We will begin to have other things that can be brought into the picture to continue to grow this exponentially.
I think to bring it back to your original questions about these timelines and the F2s and F3s, we are going to see Rezdiffra being treated in primary care in the next 5 to 7 years. These patients will not come in to liver specialists, and therefore we won't have grown a system to get to the right patients, but we will. But primary care will look after these patients very, very well because they are seeing them. They just don't know they're seeing them. They don't have the data or the non-invasive access to be able to manage them in the way that we would like them to be managed. But there was a very interesting point Jeff said there. COVID. Who was most affected in COVID? People with cardiometabolic conditions and statistically those with fatty liver disease. If we remove F2, F3 fibrosis and improve the liver fat, we know that excess liver fat tripled your risk of mortality and severity. So therefore, preparing the nation, in any nation, for a future pandemic or issues, because we had warning signs, we had H1N1, we had MERS, and we had SARS, all affecting the same population. So maybe we're preventing a pandemic issue. We're treating one pandemic to prevent another one. So I quite like Jeff's thing on COVID.
I reacted to the COVID thing in a slightly different way. I liked it also, but extreme demand on places in the medical system that were a lot smaller and couldn't handle it. And frankly, for that kind of thing, there's no way to short circuit getting to an ER emergency department unless you've got vaccines that people want to take. Here, Ken Kuzy's been talking forever about the idea that the best thing we could do is get everybody checking a diabetic patient to add a liver check once a year, the same way you check kidneys, check eyes, right? That would bring primary care into the game, Louise, in the way that you're describing, which is they could then, if the patient turned out to have fibrosis, they could treat them as part of the integrated diabetes care, or endocrinology could do. I think that's the kind of thing that has to happen, number one. And the other thing that has to happen, I was interested in what Jeff said, because too often people kind of look down their nose in the private systems at the VA as a source of innovation because of who the patients are and because of where the funding is. But here, the VA could be an amazingly rich source of innovation. I mean, I know I tried to get somebody from the VA to do something with us last week, and he couldn't because they were spending all their time trying to figure out what to do with the new Wegovy indication. And what could they do to go back into their records to identify patients who are now Wegovy candidates and where the economics were going to support doing that. So that's not so different from this. Right? It's obesity to heart instead of liver to heart and liver to other things, but not so different. Okay. So we're an hour and 10 minutes into this conversation. And because everybody's an advocate, I think we could probably do this for 3 more hours, but I think I want to start to wrap it up. And I'm going to wrap it up with a very broad question that each of you can answer really however you choose. Can you identify one stakeholder somewhere in the healthcare system, whether directly involved in liver today or not, that has a lesson they need to take out of this, or we need for them to take out of this? And who is that stakeholder, and what is that lesson? Wayne, if you can go that fast, I'm really impressed. Go ahead.
You know, the big hurdle that we're going to face is with the gastro community. We'll put pressure on the primary care docs over time to identify these people, and they're eventually going to send people into the gastro realm because there just simply aren't enough hepatologists to carry the burden. And we have so overloaded the gastro community with scoping that they really just want to, they're head down, butt up, scoping all day, and they don't really want to take time to talk with patients. And that's going to be a serious roadblock for us. And it's going to cause a lot of frustration, I think, to the gastro community. So whether we advocate for their PA, building up their PA support to handle the dietary issues and the ongoing day-to-day small things, or what we do to augment or modify in some way the gastro response, I think is going to be critical in the long term.
Good place to start. Who wants to go next?
I would like to see continued research into the MASH space with regard to the successes that have just happened. There was that spider web of molecules in development. Not sure how many dropped off because they had to or because they wanted to, but this is good encouragement for people to continue to do research so that we have options and improvements in the future.
I'd like to piggyback off of what Michael just said, because I just had the opportunity to spend about an hour with an immunologist interest in talking about this drug. It happened to be a part of the conversation. It wasn't our whole conversation. And he's actually, he's an immunologist. He needs cells to work with. And so we're moving in this non-invasive route of non-biopsy. And his concern becomes, well, how are we going to do our job without cells to work with? And so I think we're going to need to get some really good buy-in from the research community on how to do this effectively moving forward.
I think for me, it's going to be about medical, nursing and allied health education, bringing it back to our original training of those areas in the fact that we write this now into the story, metabolic health, that we get this into people knowing that liver health is intrinsic and important to that cardiometabolic space. So putting it deliberately but into medical school, into evidence, into education and in all walks, so that it becomes common language. Oh, have you thought about the liver? Or did we consider this? We wrote it out of the story. We need to put it back in. It's as simple as that. But we need to start now in training.
I'm going to fall into what I'll call the, for your Schoolhouse Rock fans, I'm going to fall into the conjunction junction here, which is, if you'll notice in the labeling, as Jen pointed out earlier, said that it is to be taken in conjunction with diet and exercise. And when you look at other medications, I think that phrase in conjunction with is actually pretty important, because sometimes they'll say adjunct to or adjunct with, but in conjunction with gives a little bit of a different connotation in this way. And so in conjunction with diet and exercise, or I prefer the terms physical activity and nutrition, those are the areas that I would point to paying attention to this, as the area of nutrition and physical activity. And there's some big battles that we got to fight there too. If I'm diagnosed with NASH and beginning to go on this medication, but the dietitian or the physical therapist or the exercise specialist isn't reimbursed and I have to pay out of pocket for that, then that stalls me pretty completely. And so it just renders, then we're not going to see the results of the medication as optimized as it could be. And so for me, that's where it is with the dietitians and the exercise specialist, I believe.
Okay, so Tony, we've not heard from you yet, and I'm going to go last because I've got at least 3 things I'm thinking of right now.
Okay, my mind is really all about education. And I think we can, if people become educated about what they're putting in their bodies and how it's affecting their liver, we can reduce the flow of people that will have to go into the medical system. And one of the things we find most effective when we go out, we bring with us bottles of Coke and Pepsi, orange juice, your Gatorade with the amount of sugar in the bottle. And it's a great visual. People see that and they say, geez, I can't believe I'm putting all that sugar in my body. And I just think continued focus on that education might help to stem the flow of people with liver issues.
So that and Jeff's comment are a good segue to my first point, which is a dozen years ago when I was being treated for adjuvant melanoma, lymph node melanoma, thankfully never got past one base, and I'm here a dozen years later. I was on a bulletin board where people were saying things like, if I can't eat fried green tomatoes, life isn't worth living. But that was at a point in time when there wasn't a lot to do for melanoma yet. So I think people get smarter about the idea that they can do something once they have hope that doing something is going to do something, if you will, in the keep it on category. So one of the exciting things about having medication is now people can be hopeful. Jeff and I talked about this a little bit in the group on Friday, also in the context of talking about diet and exercise means something completely different when it's part of a therapy that has a drug in it as compared to the only thing that you have to do. That's number one. My second and third comments are really to the investment community, although because a lot of investors listen to this actually. Number one is there will be a huge market in electronic support, because the point that Jeff made about making electronic medical records smarter at health records smarter at FDA, Wayne's point about gastros being swamped, a lot of that's got to get dealt with electronically. I agree also that a lot of it has to get dealt with through physician assistants, nurse practitioners, and better use of allied professionals, but a lot of it's got to get dealt with electronically. And it's easy to do. Someone just has to invest the money and the time to do it. The third thing is this 30-something% of this population has MASLD and 15% of this population has MASH. Then the diversity of profit-making opportunities that are going to be available is indescribable. Jen mentioned 59 diabetes drugs, right, with probably 7 or 8 pivotal modes of action over the last 30 years. Jeff mentioned electronics. We've talked about FibroScan, and there are now 3 or 4 other scanning devices, and they're all still just second generation, third generation. old-fashioned stuff. People should overcome their skittishness to invest really fast because it's going to be a major health problem and it's going to require money. And with money, things can't get done. So I wouldn't have said that 3 weeks ago. I would have said it 3 weeks ago, but I wouldn't have said it with as much conviction because getting this drug over the finish line is really the proof, right? All right. This hour and 20 minutes has flown by as far as I'm concerned. Thanks, everybody, for being part of it. I will be back, audience, with Question of the Week in just a minute. You guys, congratulations, and thanks for the roles you've all played in making this happen. And we'll talk to all of you soon.
Thank you.
Bye. Thank you.
Sirfan. Bye-bye now.
And now, here's Roger with this week's Question of the Week.
Hi, it's Roger. Here's our Question of the Week. In each of our last 2 episodes, my closing question asked panelists what messages they had for other stakeholders in the industry. Now it's your turn. Wherever in Nashville you work, you must have one good idea for what someone in another stakeholder group could do. Biopharma, diagnostics and devices, clinical research, academia, patient advocacy, direct patient treatment, just to name 6. Can you please share your favorite suggestion for what another stakeholder group can do to improve patient care, market access, or product development? You can cheat and use one of the ideas that our panelists had, but if you make an original, we'll probably like it a lot better, and I might even get you to talk about it on the podcast. Bye-bye now.
And now for the Season 5, Episode 7 Business Report.
Slava Ukraini, glory to Ukraine, and also Am Yisrael Chai, the people of Israel live. I'm going to digress shortly because not a lot is happening in the actual events in either of those places this week. So I have some questions. Does anyone believe that Vladimir Putin could win 87% of the vote, including 93 to 95% in areas of Ukraine in a free election? Or for that matter, anytime the ballot boxes weren't stuffed? Does anyone really believe that Bibi Netanyahu, who has intervened actively to support Republican presidential candidates in U.S. elections since 2012, honestly feels that for one country to make comments germane to another's electoral system is inappropriate meddling, or whatever he's saying? Does anyone really believe that Mike Johnson has an honest reason he will state publicly not to bring the Ukraine-Israel-Taiwan resolution to the floor of the House? Or that Hamas has any interest in stopping the deaths of Gaza civilians? Me neither. And these are the mounds of slop that prevent any progress from being made for the people of Ukraine, the majority of Israelis, and the innocent and endangered of Gaza. Keeping these issues alive is a pivotal thing for all of us to do whenever we can. Choroyim Slava, glory to the heroes, and also Am Yisrael Chai, the people of Israel live.
It appears that you folks liked our most recent episode.
Our Friday episode with the Global KOL team has experienced the fastest 72-hour uptick of any episode in over a year. Thanks for paying attention, and tell all your friends to download. And while you're at it, please send me a note at questions@surfingmash.com to let me know what you would like us to cover. Finally, I hope you enjoy listening to this week's episode, the one we just recorded, as much as we all enjoyed making it.
This week's Question of the Week is closely connected to the last 2 episodes.
This week's question comes virtually verbatim from today's episode, where I asked it to the panel. You can listen to the episode to get the context, and I look forward to your responses.
For next week, 2 possibilities.
I'm working on 2 episodes right now, ideas I really like. Whichever one works out, I'm sure you'll find it fascinating and informative. And the one I don't do next week, I'll do within the next couple of weeks.
The Vault is taking another week off.
As we did with Friday's episode, we will post 6 conversations from today's episode, which means we have no room for a vault. It will be back next week. And with that, I'm happy to return to our weekly schedule. I want to thank our team, Jorn, Louise, Mike, Eric, Steve, as we march ahead, and congratulate all our patient advocates who worked so long and hard to have patients' needs and visions included in the Madrigal label and launch plan. Enjoy our conversations this weekend. Please take a listen to our question of the week and, of course, reply. Until then, stay safe, surf on, see you on the podcast. Bye-bye now.
Have any questions for the surfers? You can send them to questions@surfingmash.com and we will answer on the podcast or website. Your question might even wind up being the question of the week.